Well, ladies and gentlemen, good morning. We're really pressed for time this morning, and you don't want to listen to me, you want to listen to the celebrities. But firstly, thank you all for coming. Thank you to the speakers. I know many of you come from a long distance. Please ask lots of questions, get everybody's contact cards, make sure there's follow-up after this, etc. That's why we're here. Just a few housekeeping. There's no fire alarm planned. If there is one, then we need to assemble outside that building. There is filming, so any hugs and kisses are going to be captured forever, so just be careful. But look, I was asked to say a few words, and I'm not going to stand here and tell you what a massive problem this is, because you all know that. But what I am going to do is to say what a massive opportunity Jim has given us. And, working in Oxford, of course, we're surrounded by great people. But occasionally you get a chance to meet somebody truly, truly great. And, and this happened about a month ago. Let me just share this story with you. About a month ago, I was here, sitting over there, and Louise Richardson, our Vice-Chancellor, I don't think she's here this morning, but some of you met her last night, brilliant lady. She hosted a couple of individuals, David Rubin and Simon Rubin. So these two individuals, as some of you know, have given 80 million to the university to create a new college. So David Rubin was standing here, and he said a few words, and I felt quite emotional after them. What he said was, "This is the most defining moment of my life." He said, giving this money to this university to create a new college, and the college is going to be here for several hundred years, and it's going to train several tens of thousands of students. He said, I've never done anything more important in my life. And I thought that was absolutely amazing. Jim, I think you're exactly like him. I think Jim has recognized this is a massive problem. We need real urgency. So he's thrown the gauntlet down and said, okay, Oxford, you're always telling us how great you are, now prove it. Use all the expertise you've got, use all the resources you've got, use all the infrastructure you've got, use your networks with industry, with government, with funders, with regulators, and use your international alumni network to solve this problem. So the onus is now on us. We need to make it happen. Jim, the world is going to thank you for this. So really, thank you so much for this gift. So look, you don't want to listen to me. I'm going to hand over to Jim. Jim, stop the unthinkable becoming the inevitable. Thank you very much.
Good morning, ladies and gentlemen. Firstly, thank you for the dinner last night. I know Louise is not here. She said some very nice words about us. But it is greatly appreciated that you made the effort to put on that dinner, and you all attended. It was lovely and most enjoyable. And nice to see a bit of the art collection. Including, actually, when I was wandering around with Colin, who's the curator there, I can't remember the name of the artist, actually. He was one of the better artists who'd done a couple of stained glass windows, and they're on the wall there. And they're in the church in Lyndhurst, which is where we began all those years ago. I thought, I've only got 10 minutes, but I thought rather than talk about IOI, which many people are going to do this morning, I might talk a little bit about our journey as to how we got to IOI. I mean, it's quite a long journey in a way, because it starts with the beginning of Ineos. So maybe if I take you down that road a little bit, and then we're going to spend a lot of time talking about bacteria and resistance and all that type of thing later. So Ineos, Chaz, you talked about me, but me is actually John, Andy, and myself. There are three of us in Ineos who are the shareholders of Ineos, and we are all, David described us last night as we're all northern blokes. But we're all northern grammar school boys, one from Sunderland, one from Doncaster, and I'm from Failsworth in Manchester. So our roots are in the north. We sort of came together actually 25 years ago now. It's 25. We have a 25-year anniversary next year. And we started this company called Ineos. We've been quite successful. And, you know, Ineos used to be known as the largest company you'd never heard of. Until about 5 years ago, when we sort of hooked up with Lewis Hamilton and one or two other sports stars, and as a consequence, we've sort of become a bit more. But there was also that gin and tonic I had in the pub called the Grenadier in London, some of you might know it, where we came up with the idea of getting involved in the car industry. And the Grenadier obviously has become sort of reasonably well known, which launches, interestingly, next month. But we might be not particularly well known, although we're becoming better known, but we are quite large. And it's sort of, I know John and Andy were talking to one or two people last night who really didn't know that much about Ineos. So I thought maybe I'd spend a couple of minutes talking about it. So Ineos is petrochemicals. It's predominantly petrochemicals. 90% of our profits come from petrochemicals, but we're also increasingly large in oil and gas. You're going to see us, whether you like it or not, on the road in automotive. We have a fashion company, Belstaff, and we have a number of sporting interests, which I'll talk about in a moment. But so our bandwidth is quite wide, and we continue to grow quite quickly. So to give you an idea of scale, we're probably about 2 times the size of Barclays. We're about 2 times the size of British Telecom. We are 4 Rolls-Royces or 4 Marks and Spencers. And we're bigger than Tesla or Dow or McDonald's or Nike or Coca-Cola. We're all obviously much better known than we are. We are becoming better known because we recognise that with an automotive offering and, you know, a little bit in fashion, that it is quite important that you have a brand that is recognised to a degree. So we got involved in sport. So for those of you who don't know, we now own a third of the Mercedes Formula One team, along with Mercedes, equal share with Mercedes and Toto Wolff. We have one of the world's best cycling teams, used to be Team Sky. We're about to have our second go at the America's Cup, which is the oldest sporting competition in the world. I think it's 170 years old, but despite that phrase, Britannia rules the waves, we don't actually have the cup in the cabinet yet. So we're going to have another crack at that in Barcelona in 2024. And then we have this quite close relationship with Eliud Kipchoge, a wonderful man, probably the greatest athlete ever, certainly long distance, and the All Blacks, who, of course, we're going to meet later today. And it's going to be quite difficult to know who to support the day after. So we have sales of about 60 billion-ish. It's growing quite quickly. Peak profits, I mean, it goes up and down because we're in commodities, but peak profits, and our best year was about $10 billion. So they're quite big numbers, really. And so Andy, John, and myself, you know, we do have a bob or two now. And there comes a point where, you know, if you're a cyclist, there's only so many bicycles. I like cycling, you know. There's only so many bicycles. Really, you can justify. I mean, you can carry on buying them. You know, there comes a point where it gets a bit silly. So, as Ineos has sort of settled down as a business, and it's matured, and you know, the key thing. I mean, it's the same. I'm sure in the university, the key thing is to get the right people doing the right jobs, and things start to run in a well-oiled fashion. It becomes low maintenance. We can look at doing some new different things, hence oil and gas and automotive and things like that. And it does give you time to dwell on what might be some of the good things you can do in life, rather than simply being utterly focused on your business, which is what we were for 20 years. There was nothing else in our lives for the three of us than running Ineos and growing Ineos. And to get Ineos from where it is to probably today the third largest chemical company in the world, 185 sites, 25,000 people everywhere in the world, from China, America, the Middle East, what have you. That sort of total focus. But there comes a point where you start to, think a little bit more about what you can do in the world that might be a good thing. You have some social responsibility. We have a lot of money to play with. I don't like this word sustainability, but Ineos has these sort of three pillars. We describe them as the three pillars of sustainability. But they're things that we're doing which I think are good for the world. And pillar one is about Ineos becoming, and you'll have heard a lot about this, and people do speak rather glibly about it, but about Ineos becoming carbon neutral by 2050. So if you think about Ineos, we're petrochemicals. We're involved in some form or another in just about every material on the planet. So from wrapping your food to what keeps things hygienic in the hospital to, your iPhone, the cars, planes, the insulation on electrical cables, everything you think about. So unless you want to live in a dark, cold cave, naked, you really do need us. It's fine talking about, we don't like hydrocarbons and all that sort of thing, but at the end of the day, nobody wants to live in this dark, cold cave. You rely on. But having said that, so I think what we do is a lot of good in many, many ways, and we make things that people need. But we do have a carbon footprint, and that carbon footprint is in excess of 20 million tons. So it's a huge number. So one of our duties, I think, to the world is to find ways of eliminating that. And we have 185 sites. So this is, and each site has its own particular problems, and the solution will be different for every site. But just to illustrate that we can get there, which we can, we have one large site in America called Chocolate Bayou, great name, just near Houston. And it's about the size of the city of London. Makes a huge amount of chemicals, it's a big petrochemicals complex. And it has a footprint of 3 million tons of carbon dioxide. And we have a map which takes us to 2030 from 3 million to 1 million, and by 2050 to 0. Now, not all of that is absolutely laid out, but we know what the map says. And we know it's a combination of using hydrogen as a fuel, using carbon capture. We will build a solar farm of 2,500 acres, which is the same size as a Scottish estate, and becoming more efficient, conserving energy. And the cost of that will be 5 billion, maybe 6 billion. So for Ineos in total to get to carbon neutral by 2050, that's 50 billion. And when the politicians talk about carbon neutral, they sort of forget that, there's a capital sum along the way that is incalculable if you're talking about a country. But there is a route there for us, and it's quite important for us, and it's mapped out, and we're on that journey. And we won't say we've said that we'll get to a 30% reduction in our carbon footprint by 2030. We won't say that unless we know how we can get there, and we know how we can get there. So that's pillar number one. Pillar number two, if you think about the journey that the world has to become not necessarily carbon neutral, but highly reduced in terms of its carbon footprint, because I don't think we've seen the full consequences yet of, this blanket of CO2 up there. Two of the essential components to achieving that huge reduction in CO2 are hydrogen and carbon capture. And hydrogen, you're either going to make hydrogen from water or you're going to make it from natural gas, CH4, methane. If you make it from methane, then obviously if you split the hydrogen off, you're going to be left with lots of CO2. So that involves carbon capture itself anyway. But if you make it from a water molecule and you electrocute a water molecule, using green electricity, then clearly that's quite an attractive fuel for the future. You burn hydrogen, all you get is water, and you can produce it carbon-free. And that's a process of electrolysis, and Ineos is the largest industrial operator of electrolysis units in Europe. There is nobody gets anywhere near Ineos in terms of that experience in electrolysis. So we're going to be there in hydrogen in a big way, I suspect, in the future. And are you nodding at me that I'm over time? Am I over time already? I'm only halfway through. I think that's my first ticking off. So wave at me if you want me to shut up. I'll just shut up, I'm quite happy to. But anyway, so Pillar 2, carbon capture is the other one, and we're leading the first major carbon capture project in Europe. And there are about 6 or 7 of them. The first one will be in Denmark, and Ineos is leading that consortium. Pillar 3 are the more discretionary projects, and we were talking to Neil Mortensen last night. Oh, there you are. About if you do medicine as a young man and you qualify in medicine, how do you decide where you go after you've qualified? How do you decide whether you're going to be bones or bowels, as Neil put it last night? And with these projects that we're talking about, it's a similar, it's who you met, who you bumped into, what sort of thing sparked an idea in your head. And if you look at the special project, that's basically what's happened with myself, John and Andy. And we have 4 special projects. By far and away, the most important project that we're involved in is AMR. There's no question of that, because that has the potential largest impact on our species and the planet, really, I think, IOI. But the 4 projects, have I got a minute or not? I have. I've got 1 minute. The 4 projects are quite interesting. The first one, so I'll speed up. The first one is wildlife. So the Selous is a wildlife reserve in southern Tanzania, and it's the largest wildlife reserve in Africa. It is the size, it's bigger than Switzerland or Denmark or Holland. It's 3 times the size of the Kruger or the Serengeti. But we, species, the Homo sapiens, have exterminated all the wildlife. It used to have the largest population of elephants on the planet. There are none left. There's not a single black rhino left, and there were 2,500 of those. So that's just because we've been involved in this discussion with the Tanzanian government, has been converted into a national park. So hunting now, the only people these animals have ever seen have been the hunters or the poachers. So they've not had a great time of it, really, and they've lost that battle, because all species on the planet lose the battle when they meet humans. So that's been converted into a national park, and we have finished up with the job of trying to rehabilitate that vast piece of wilderness in Africa. So that's quite a good thing for the planet. I think I'm quite pleased that we're involved in that. We have something similar with the North Atlantic salmon in Iceland. Iceland, middle of the North Atlantic, no people, 300,000 people, but they all live in Reykjavik. Nobody lives at the top, and we're sort of looking after these rivers at the top. And if any of you are fishermen, this is the finest salmon fishing on planet Earth. It really is the best fishing on planet. It's all catch and release, but forget Scotland. There are no salmon left in Scotland anymore. Anyway, the third one, still looking at me. The third one, I've got 0 minutes though. The third one is child obesity, and I think I will mention it, even though I'm getting into trouble on the front row. Child obesity, I think, is the biggest issue facing children today. And we started this programme with a Scottish headmistress a few years ago called The Daily Mile. And the idea is that children below the age of 11, when they're very impressionable, they run a mile every day with their teacher. They don't bother getting changed, but sometime during the day they run a mile. And now we have 4 million children around the world running the Daily Mile with their teacher under the age of 11 in 85 different countries. And that is taking off enormously, and it's a great thing. But of all the great things, I think, this challenge we have. I mean, Ineos, we've got to where we are today because we've embraced challenges of one sort or another in a business, and, Elliot and his 2-hour marathon. But all of, when we bought BP Chemicals in 2005, which cost us $9 billion, we had sales of $8 billion, BP Chemicals 25 billion. That's quite a big challenge, really. So we're so used to challenges, but this, I think, is one of the biggest challenges. And I remember it all kicked, for me, my mind departed from my body about 10 years ago in a sporting sense, and as a consequence, I started to spend more time with these orthopedic chaps in London than I might have liked. So I kept falling off things, skis and bikes and motorbikes, things like that. And so this was one of those chance encounters, really, that I was talking to, like Neil and, you know, your bowels or your bones sort of thing. And, you know, I remember that initial story of the President of the United States in 1920. His son played tennis, and 5 days later, he died because he had a blister and he got sepsis. And that's unthinkable today. I mean, maybe if you're scaling, you know, El Capitan, you might, you know, be nervous, but you're not nervous when you play tennis. We don't think about the consequences. You know, the flip side, given where the trajectory is, which we're all going to talk about today, and everybody knows that, you know, that antibiotics are being defeated at the moment by bacteria. But the thing that always sticks in my mind, in particular about this project, is, you know, I remember when I was at school learning about the Maslow's hierarchy of needs, and you remember at the top of the Maslow's is procreation, so which we quite like. But can you imagine in 20 or 30 years' time, if we don't have a cupboard full of antibiotics that we can rely upon? I mean, would you or would you not have children if you know that if you need a cesarean section, you're playing Russian roulette? I mean, you can't, it's unimaginable. I mean, Ursula is just about to embark on that very process, but you're not worried about the cupboard with the antibiotics if you have to go down that particular road. So it is unthinkable. So I think it's a fantastic cause, and I do hope that this relationship between Ineos, which is a slightly unusual organisation but has been very successful, and Oxford, which is the finest university on the planet, although my two colleagues who just over the county border might say it's one of the finest universities on the planet. I think that union of the two of us, I do hope we put politics aside and get really focused on, we need to find new animal antibiotics and we need to discover new human antibiotics. That's really what this is all about. So, thank you. I apologise again.
You could tell Jim was really enjoying himself there, wasn't it? So it's impossible to tell your donor to shut up, isn't it? But Jim, thank you. I mean, you know, we all worry about problems, and we all worry about bringing together all the different stakeholders and coming up with solutions. And when you have that sort of mentality, it's so easy to get passionate about everything, you know. So it's great stories. Thanks so much. And you're the guy who's looking after his bones. Who's looking after your bowels, Jim? I don't know. So, okay, thank you. Hanan's been waiting patiently. Hanan from the WHO, AMR, a public health concern in need of an orchestrated response. You're going to tell us what to do, Hanan. Please do. Yeah, thanks.
I think I have some slides. Good morning, ladies and gentlemen, and thank you for inviting me to this amazing institute. This is my second time, and I just want to say that it was a true pleasure because I worked with the Jenner Institute on starting the first human phase 1 clinical trial in Saudi Arabia, where I am originally from, several years ago. So it's a true pleasure now to come and be invited by you. So thank you for this, and thank you for the IOI for all the great work that they're embarking on. At this moment, it's been 3.5 years for me moving from my clinical and academic world, where I'm a pediatric infectious disease person for 21 years, dealing with pediatric patients and infectious diseases, complicated ones. I did my training during the peaks of HIV in the US when no medications existed. And the HIV patients kind of really made me want to go deeper and deeper into infectious diseases because the general surgeon of the US many, many years ago said it's time to close the books on infectious diseases. And boy, was that a wrong statement. The bacteria and the resistance to antibiotics is not new. It's as old as the existence of bacteria. So I think the issue that we're tackling today needs to move from saving antibiotics to more of this is a public health disaster that has existential threat to modern medicine itself and to human existence. So I'll touch a little bit more on that in details. But I think also this type of data that you're seeing, and I won't talk too much about bacteriology and resistance genes, but I want to tackle this more as a public health agenda. The fragmentation in the response today to AMR is what's the most concerning to me. If we look at some of the data, and I'm happy to share the slides with all of the references, one child dies every 3 minutes from a multi-drug resistant organism. The newer data that came out of the germ study, 1.3 million people passed away in 2019 from death attributed to AMR. 5 million associated death. And for me as a clinician at the bedside, I think that that's a significant underestimate. 28 million people will be pushed into poverty. And if we want to talk about economics and what's going to make people tick to address this issue is to look into the economy, because the human health is extremely important, but I think the country economies are much more important. And that's going to be the drive for AMR. 1 trillion additional healthcare cost and 7.5% decline in the livestock. Now, when I chose the title, I chose the word orchestrated. And coming from academia, coming from the bedside, coming from a research institute, from a new research institute where I initiated the infectious disease AMR platform 10 years ago, and I remember inviting Tim over when we were still with the blueprint, we were trying to address what are the types of research and how do we deal with these bacteria, and it's very, very complex. But at that time, I wasn't aware that 70% of the antibiotics produced today are used in the animal sector. So that's one problem. The other issue is that it's also used in the agriculture world. Now, the fact that the antibiotics are in the animal sector and in agriculture sprayed as part of camouflaged under insecticides, camouflaged under the word growth promoters, but backyard farmers, people who don't understand the makeup of the medications and the treatments they're giving to their animals, deep inside those concoctions are antibiotics. That causes a big problem because we are unintentionally, so we talk about doctors not prescribing well and patients taking, but they are unintentional, we're unaware of the exposure to antibiotics through the water, through the feed, and so on and so forth. And that's why it was very important for the orchestrated response among the human, animal, agriculture environment. Apart from all of the bigger stakeholders, and this is an amazing stakeholder in this room as we speak today. So the WHO actually is an organization of a major office in Geneva, 6 regional offices, and 152 offices. We are a member state organization, and we serve 194 countries. And our mandate is dictated by the executive board, which goes in cycles of 33 countries every 3 years. And these are the countries with the other member states that mandate what should we be doing. And the reason why I have this position, and you kindly introduced me as the first ADG for antimicrobial resistance, is because member states are anxious. And they want an orchestrated response for antimicrobial resistance, and hence the division that I'm leading right now. And it's put a lot of burden on me because now I have to think more as a public health diplomat, public health person, and not a pure clinician who's only looking at the human threat. This is a public health, global public health, high income, mid-income, low mid-income country problem. With each one of these economic income countries have their own uniqueness in what they're struggling with and what their challenges are and what their solutions are going to be. and I'll try to tackle that a little bit. So the One Health approach and the integrated surveillance needs to be supported by sector specific. And that's where, for the audience who hears the word One Health a lot, One Health is more of a trend where we're saying we need to work together, but the animal sector needs to do their part, the environment needs to do their part, and the human health, which I'm leading kind of in two ways, but the human health sector has a part, which I think most people are aware of that. I won't give the details of this timeline, but I'll say that in 2015, a global action plan to try to guide the member states on where can they start came out. It had 5 major pillars. And then after that, I was appointed by the Secretariat after UNGA, the Secretary General Guterres had asked for the 4th only health topic to be addressed in New York was AMR. And we worked for 2 years. We came out with recommendations called the Interagency Consulting Group. And there were 4 major governing bodies that had to be, or governing entities that had to be established. And one of them was the Quadripartite. In the Quadripartite, we have, when we say Quadripartite, it's the 4 big organizations: the World Health Organization, the FAO, the Food Organization, UNEP, the Environment Organization, and the Animal Organization, known as OIE, and now known as the World Organization for Animal Health. And we work together very closely because if Dame Sally was here, that was one of her biggest frustrations as one of the biggest champions of AMR. And I really wish she was with us, but that was one of the first achievements that we had to do, is to bring the 4 organizations so we align on our goal. Because if the animal industry and the agriculture industry continues to think about the economy in silo, they will not come to solutions that will serve the AMR from the human health perspective and also from the animal perspective. And we've been working, even under the pandemic for the past 2.5 years, really hard to align the vision of those 4 organizations. And here you can see in 22, we were able to get UNEP as part of our organizations, as the Quadripartite. Now, if you ask us, what do we do as organizations? How are we going to mobilize 194 countries? They asked for a global action plan. We produced a global action plan. And now we're asking governments that you need to produce a national action plan that is customized for your specific problems, that you can put your own KPIs. And what happened over the past 5-6 years is that we had 149 countries out of the 194 have a national action plan. The sad part is that in classifying how robust these national action plans are, E is the best. You can see only 10% of the countries have a national action plan with real KPIs, monitoring and evaluation, and funded. And that's a problem because it means it's ink on paper. And we're very blunt about that. And we need to move into finding solutions. In a large member state consultation, we tried to understand what is the biggest problem of these now. We know the problem. People are dying. Modern medicine is being jeopardized. People will no longer be able to get their hip transplants, their liver transplants. They will not be able to have safe cesarean sections. But also, a lot of people in low-income countries don't even have access to antibiotics. People are dying from lack of access to affordable, effective, and timely antibiotics. So what is the problem here? It is funding and coordination in these word clouds that was done by the participants of this specific activity. So in the Quadripartite, we have 3 major areas that we're trying to tackle: is our collective work together, the global governance structures and the political engagement, and then integrating antibiotic or antimicrobial access, R&D, and regulation. On the Quadripartite, I won't get into the details of this. It can be a little bit boring, but again, I'm happy to share the slides. But it is to share common visions on what we do. As an example, we have next year the human health and the animal health regulators meeting for the first time on regulating antibiotics. The WHO has created something called the critical important antibiotics. This is the toolbox we need to save for humans. And it's okay for you to use these antibiotics for the animals and the agriculture. Seeing eye to eye on that was a big deal. Because again, the communication between the organizations and the The agenda of the different organizations, even at the government level, are different. So we're having a regulatory, that is a crucial achievement that we were able to establish. And there are a few other areas that we're working together to align. Why is it important for the environment and agriculture and fisheries also to work on certain areas to secure the effectiveness? Not to be grim, but on the antibiotic production, there are several entities and they need billions of dollars to produce innovative antibiotics. But till today, when you ask them, there is no resistant proof antibiotic that's going to come to the market soon. And the resistance develops within an average of 2 years. So we're putting $1 billion to produce 2 or 3 new agents with a return on investment of less than $50 million, and for that antibiotic to potentially be ineffective within 2 to 3 years. Because there's no regulation, there's no stewardship, there's no good hygiene. And antibiotics, by the way, in many institutions, even if you go to the top-notch hospital around the world, sometimes antibiotics are used because of lack of hygiene. It is used as a substitute because it's cheaper to give out antibiotics than create a farm that conforms with good hygiene practices. The same thing in the hospital setting and the same thing in the environment setting. So these are just some of the works just to reassure you, for those of you who are aware of the Quadripartite, we are really aligned and working together. This is the Global Governance Group. So out of the 4 entities, the Global Leaders Group, and Sally Davis is with us on this. This is very important because we never had that political noise. And this is a group that is chaired by 2 prime ministers. Prime Minister Mia Mottley of Barbados, who's a huge in climate change also advocate, and Prime Minister Sheikh Hasina of Bangladesh. So I think these are 2 strong leaders with a very strong, robust group of ministers, ex-ministers, and partners. And they've created a lot of work for the Secretariat. We call ourselves the Secretariat. And we're very happy for that work. And they've identified KPIs on what is it that they need to achieve. I think, Jim, you might be very interested to read their brief notes because they're done for the public, and the climate crisis one is how do we link climate crisis with AMR? And the melting of the ice, I wasn't even aware of that, and it's releasing bacteria with resistance mechanisms that are thousands of years old. So the resistance issue is not new, but it's how we're dealing with it. It's us living in crowded communities, in less hygienic. There are over 2 million people who actually drink water contaminated with feces. So that is an AMR problem, but it's a dignity problem, and it's a big public health problem. But it feeds into the AMR situation. They have also produced on financing and surveillance. The pandemic accord, which is coming out because of the pressure we had in COVID, the pandemic accord is a binding. Finally, the member states identified it being a binding accord or treaty, and we're making sure, or we're hoping that the member states make sure that AMR gets included into that language. There are other examples of us moving into our activities, and we already have a high-level meeting in 2024 on AMR, and we also had a side event this year at UNGA in New York. Also, this is very political community that's attending these meetings. Today, and I'm going to have to excuse myself for 40 minutes to attend the launch of the Multi-Stakeholder Partnership Platform on AMR, which is another area for the stakeholders to communicate their work and to bring the shared vision on the antimicrobial response. The MultiPartner Trust Fund was launched in the 2nd Antimicrobial Ministerial Conference. Me and Otto were there, and as you can see, it's a fund of 26 million so far. So small amounts of money to produce grants that are catalytic to the AMR response at country level. And this is one of the areas that we felt would have helped bring attention to the governments on how do they end up looking into further funding on the AMR areas within their national action plans. Unfortunately, it was launched and we were bombarded by COVID again, so the movement on this fund is quite slow. We're going to Oman. After this stop, I have one stop in Riyadh, then I go to Oman for the 3rd AMR Ministerial Conference in Oman. And the Quadripartite has worked really hard with the Omani government in identifying the outcome. We don't want a ministerial conference for statements. We want it to have impact. And one of the first things that the Omani leadership looked into also is that, and we very much agreed on, we don't have targets. So if we want to reach a specific goal, we have to have milestones and we have to have targets. And for the first time, it was very, very difficult, and Otto was also with me on the ISAG group, to have targets specifically for the animal sector is extremely tough. And I think the Muscat Manifesto, for those of you who are interested to look into it, it's online and has the details of these targets on animal and human use of antimicrobial agents. Then integrated antimicrobial access, R&D, and regulation, a very difficult topic to tackle. And the WHO is the center of trying to orchestrate this work. And when we talk about R&D, we talk about, from the beginning, the WHO's role in prioritizing, coordinating the pipeline, supporting R&D, and supporting access and appropriate use. And on the right-hand side, you can see some of the examples of how does the WHO does it work in prioritization. As a neutral entity, as a neutral body that serves its member states, we are in the best position to bring the experts, and that's how we function. We have expert groups to bring, as a neutral entity, bringing the prioritization and looking into what is on the market, and we do that for vaccines, for diagnostics now, and for therapeutics. On the coordination of the pipelines, so you can find that also on our website. Supporting R&D, we have been critical in establishing GARD-P with DNDi, and also we were part of the AMR Action Fund, and we work very closely with CARBEX and the other entities. On the support to access and appropriate use, this is the one statement, but again, from the clinical bedside, it is extremely difficult to convince doctors to give or not to give antibiotics or to de-escalate. It's easiest for a surgeon or an intensivist who has a very sick patient to give them broad spectrum antibiotics for a very long time and not lose that patient. But then at the same time, the long consequences could potentially be resistance. So we have issues with the high-income countries on the appropriate use and de-escalation, but we have, again, as I said before, the issue of access. And the WHO is working on two fronts here, and we're at the very early stages. Number one, developing the medication diagnostic supply chain that starts from the beginning to from end-to-end solution. And we want to ensure that the old and new antibiotics that come on the market are accessible by everybody everywhere as global goods. And at the same time, support the diagnostic part so that also the diagnosis and diagnostics are available. The diagnostic tests are 3 to 4 times more expensive than the pills. And people are getting access to pills by the pill, not even by the course. And that just feeds more and more into resistance. The second entity that we're working on is the secure entity with GARD-P, and we're trying to ensure GARD-P is another entity that has an agenda of producing antimicrobials by 2030, a few new agents, and they want to make those antibiotics affordable and available to low mid-income countries as soon as they become approved. So instead of it taking its long term of intellectual property, it will be available, and we're trying to see how can those antibiotics be available but also used appropriately. So these are the two entities, the secure entity and the antibiotic facility. I'll skip that slide. Now to my last section is the country impact with a focus, and I'll talk a little bit on the human health sector, is, as I said before, antimicrobial resistance is not just about antibiotics. It needs to be a public health agenda, and it has to have a programmatic approach to it. And it has to have the patient at the center. Economies are important, and I mentioned the 7.5 reduction, but the patient is the essence of this specific global good, whether it's access or whether it's appropriate use. And we're trying to work on several areas. Number one, we worked on, again, this is UN jargon, the UNSDRF, and this is where low mid-income countries have to have cycles of looking into national funding on certain priority areas. And it's our role to help them include AMR in that. Otherwise, it will include development, it could include HIV, but it's not including the sensitive areas for antimicrobial resistance, and that's our role. The second thing that we're doing is the WHO Diagnostic Initiative. It's also something that I mentioned before. It's knowing what we're dealing with at the human health sector, and this is something that is hopefully taking off soon. And the third one is trying to learn from other diseases such as tuberculosis. We have a platform called GLASS where convenient data are produced and plotted, but what it's not doing, it's not producing data that is nationally representative that can lead to policy development and policy guidance to the governing, to governments. And that's what we're looking into using a two-pronged approach. This is what's happening in tuberculosis. The light brown is where surveillance of countries that have diagnostic ability, and the dark brown is where surveys are done every few years just to get an idea of where are they at with this specific disease. So this is the platform where we're trying to initiate national AMR surveys, starting from developing of the technical guidance and piloting some of these surveys. And this is also it was triggered also by the GRAM data that showed modeling specifically in countries that did not have data. We need to fix that problem so we know exactly what we're dealing with and how big the problem is. Building the country capacity for sustainability. And again, not going in and doing 1 or 3 projects and leaving the country again with nothing except for data for global consumption. We want data for local consumption that serves the patient first and foremost, then advices on policy, then they can have sustainability. Scaling up those periodic surveys and leaving behind what would be helpful to them, inform and evaluate policy intervention. We're hoping to start a pooled fund for this we might launch it early next year. And I think with that was my last slide. So I want to reiterate the fact that as my previous speakers had said, people in this room know what AMR is. We need to, though, think about it as a public health problem that is extremely complex, and we need everybody. And that's why I told Tim when he first invited me that I will be at this meeting, because it's important that we speak together, all of us, on how are we going to move forward with this problem. Sustaining global leadership is extremely important, but coordination is important. From the WHO perspective, what we see in our countries when we visit, and I was in Copenhagen with our Euro colleagues, there's a lot of fragmentation at the country level, and a lot of donors with good wills want to go in a specific country, but there's overlap, duplication, and gaps. And that needs to be orchestrated and coordinated. For country impact, we need national leadership, and that is still not there because governments have competing agendas. So are they going to put economy, food, security, AMR? How are they going to do it? That's why we do not want this to be siloed programs. It needs to be integrated. National representative data is important, and that was my last slide that I had showed you. And innovation, innovation, innovation. If we can create innovation in infection prevention control, innovation in diagnostics, innovation in therapeutics, innovation in thinking, innovation in partnership, then we can probably reach some solutions. Thank you very much for your attention.
So let's take a couple of questions if we can. So maybe I can kick off now. I'm just thinking when we were doing the vaccine in this great university of ours, we got one company, we got one university, one government, one regulator, and then a couple of funders. And it was a bit manageable, it was compact. If we'd tried to bring together all the countries and all the companies and lots of universities, we wouldn't have done it. So how do we break this down into bite-sized chunks?
A great question. It depends on which area we're talking about, because I think the sound bites for the vaccine development, it cannot be done in countries who don't have Oxford, right? I mean, there are countries that just don't have the scientific backup, and this is not easy business. But I think what we learned also from COVID, by the way, I think we need to learn more from the COVID response, is that when there is collaboration, solutions can be reached. When it comes to innovations on simple things, I'm saying simple because public health interventions, in my humble opinion, are way more complex. You have the money, you have the science, you produce the vaccine. But how many vaccinations took place? and how many treatments took place. So that's the problem. So breaking it, that's why I think the central part of our role in WHO and the UN agencies is to make sure that all of that good that is being made in these institutions actually reaches people. The COVID vaccine, for a long time, less than 15% of Africa got vaccinated with the COVID vaccine, when high-income countries were reaching 70% of their second and third dose. So I think what you're saying is absolutely right, and I don't think the expectation is that every country does the vaccines and therapeutics, but I think every country needs to be supported so that they can regulate. One last comment on that. Some of the new therapeutics are not even regulated in high-income countries. So the regulatory processes and the supply chain is another challenge that we could come together on.
Fantastic. One last question there, please. Wait for the microphone.
Sorry. Thank you, Professor Hanan, for that wonderful talk. I was listening. My name is Chioma, and I work with the IUI. I was listening to the 2022 National Action Plan Assessment webinar by the WHO a few days ago. And one of the things that came across was that across countries, we've seen level of awareness on AMR decline, across the board. And now we're talking about developing new antimicrobials, getting new innovation and all of that. So I'm just keen on knowing the strategic framework of WHO to ensure that all of these efforts won't go into futility if the people who are using these antimicrobials are not really aware of the impacts, the public health impacts, and the devastating impacts it has. So how do we now build awareness again to make it what it used to be pre-COVID?
Thank you very much. I think even pre-COVID is not the ambition. I think it needs to even be beyond that. But I reached a point, and we were discussing this a little bit last night. I don't think that every person of the 8 billion people on Earth need to be convinced, because we've seen the pushback. There are people that you're not going to change their mind, and they may not be aware. And that's why I feel it's our duty and responsibility for those of us who are in this business is that we set the stage for the correct things to happen. So from a clinician's perspective, it's not okay to give antibiotic without knowing the diagnosis. But the struggles that the physicians are having, they don't have a clinic, they don't have a diagnostic test, and they don't have a therapeutic. So our focus is to really make sure that they also have the tools. The awareness campaigns, by the way, and the behavioral change aspects of antimicrobial resistance are very complex and are very community specific. And I've lived that with MERS corona, with brucellosis, with salmonella, even with the emerging. So I think that for me is a moving entity that will continue, but I don't think that the expectations should be that you're gonna, in any time that you're gonna have a group of people talking about a disease, you're gonna find a million different opinions. But definitely it is part of the 5 Global Action Plan pillars. It will continue to be one of the Global Action Plan pillars to ensure that antimicrobial awareness continues. And I think we're missing a huge movement of civil society, and maybe Otto is here, he might address that. But I think we don't have a face for AMR to make sure that the lay people understand the topic very well. And that's something that we're trying to find innovative and creative ways of that happening.
Hanan, you're the face for AMR. Thank you very much. Thank you. Okay, thank you very much. Otto is going to tell us 16 years' work in 10 minutes.
Well, thank you so much for inviting me to this fantastic, beautiful town and this building here. Yes, I'm going to reflect on what we have been doing in REACT for some time, 16 years, really big glimpses. I will echo a lot of what Hanan, excellent talk, already told. And I know what some of these pieces and challenges I will deal with will also come back in much more depth during the later talks in this session. I'm an infectious disease physician. I've been working in the clinic, working in the research lab, an AMR, and I was a lot in policies in Sweden and internationally.
I normally feel a bit depressed after hearing myself speak. But, you know, as Sir Ratcliffe said, we need to think this unthinkable, and we need to act likewise upon it. But there are glimpses of hope, I hope. And I think you pointed also to some of those, Hanan, very, very good. Now, REACT was founded 16 years ago in 2005, and our main funder is SIDA, the Swedish Development Agency. We are still a very small network. We are around 30 people around the globe, working in 5 continents with nodes, as we call them: Sweden, US, Ecuador, Zambia, and India. And our network includes physicians, microbiologists, pharmacists, communicators, public health experts. We work with science communication. We work with supporting developing countries with national implementation, national action plans. We work with mobilizing community action. And ever since we started, we have been strongly advocating for a new research and development model that is needs-driven and overcomes all the barriers along the pipeline. And I hear also again what Hanan was saying, that this is also something that now WHO is taking very seriously. We may come back to that in the discussion, because it's really, really critical that that asset is always available. We look upon antibiotic resistance, or antibiotics rather, antibiotic effectiveness as a public good. And our mission is to secure equitable access to all in needs. The trigger, and Hanan and you may not know this, but the trigger was really this. Way back in 2001, there was a strategy, global strategy from WHO. But unfortunately, there was no implementation plan and no financing, and very little happened really. And a small group at that time in WHO was not able to drive it forward. We discussed with WHO and other leaders in the world if we should come up with something that could support the global action around this difficult topic. And that happened in 2005. So that was the first meeting we had, and the idea was to bridge this scientific, technical issue into political and social action. Now, WHO is much better equipped when I have a strong leader there. It was, what has happened over the years is that the interest in the multi-sectorial and multi-complex issue of antibiotic resistance has increased tremendously. This is an exponential curve in the PubMed database. How is this coordinated? How much is duplication? How much is gap analysis? There was a proposal from the Interagency Coordination Group on producing an independent expert, an independent evidence panel, and that has not seen light yet. I think that is absolutely something that we need urgently to really get a grip on the massive science which is out there. But having said that, there are also gaps. And again, coming back to what Hanan was alluding to, there's a country self-assessment survey on antimicrobial resistance. And you can see the question was here is if the country is using relevant antimicrobial resistance surveillance data to inform operational decision-making. And the answer was no in the red zones here. So basic knowledge is clearly lacking in very many countries. And the next slide shows even more clearly a study from a group, several groups, including African Union and African CDC, in making a case for local data that could guide therapy, because flying blind is not something that we like to happen. Guesswork is what's happening really now in many places of the world. You don't know anything about resistance, antibiotic use, effectiveness, and you take what you have. So this is an urgent call for much better local data and generation of maybe through point prevalence studies or other means to really get there. Through our policy research in REACT, we have been actively working to link also antibiotic resistance to many of the other global health issues, not the least the effect it might have on or jeopardizing the fulfillment of several of the Sustainable Development Goals, not least health, food safety, food security, environment, poverty alleviation, and many more. And also link it to universal health coverage. It was a little bit of a disappointment at a high-level meeting in the United Nations when only five, maybe 6 countries raised antibiotics as a very important part in universal health coverage. We also addressed the financing issues around this. I will come back to that a little bit. And also worked with open consultations and working together with the big organizations, WHO, FAO, and others. And worked also for and advocating for a stronger AMR global governance, where we're calling for transparency, civil society inclusion, and monitoring for accountability. A few other things that I'd like to mention is also we're working to stimulate future champions, students, leaders, and to really take this on. A very special initiative I also like to allude to is the fact that there is an antibiotic resistance coalition, which is 30 plus civil society, environmental, and other organizations supported by the Secretariat at REACT in North America. So civil society, and this is what my main points in my talk, civil society, including professional organizations, has a tremendously huge role in working together with the governments and implementing the national action plans. And we have also a toolbox, which is an online repository, where you can have inspirational examples. It is targeted primarily for the low and middle-income countries. So that is absolutely a great asset. There are many more out there of the similar kind, but we need to do better, even better. This is a difficult issue to really describe, explain, and to guide and create the behavior change that is needed. So a very blunt, open comment from the Minister of Health in Zambia at the launch of the African South Center Conference last summer. If community members do not understand the language we use when addressing AMR, we have done nothing. So we are there. To convince the society as a whole, we need a better language. Where now the most popular one today is the silent pandemic, but we have had others during the many years. It's not easy. It's not a disease. There are no civil society organizations specifically addressing this, like HIV, tuberculosis, malaria. So we have some important barriers that we need to overcome. And we need to work, as Hanan also alluded to, much more with behavioral scientists, social scientists, to really get, this is context specific. This is not one size fits all. It needs to be there now. And I will show you one case from what we're doing in our colleagues are doing in India. So, obviously, there is a lot to do still with moving science to policy. But maybe the next step is even more difficult, to move policy to implementation. There are well-known barriers like political will, financing barriers, capacity limitations for governments that need to take the steps in implementation of the national action plans. Therefore, they become often short-term, they are driven by donors, it doesn't become sustainable, it's fragmented and not integrated in the whole of government actions. So this is a huge burden on a country, specifically those that are less resourced. And to just show one picture about the complexity, this is from a recent article that REACT published in the Lancet Global Health. There are many, if the goal is really to have sustainable access to effective antibiotics, much need to happen. These pieces need also be coordinated in a sustainable long-term action. It needs to be embedded in the financing structure of the government. It is not yet. So, prevention for sure, data generation, awareness and behavior change, access and conservation, all need to come into place. This is huge. This will take a long time, and we need to meet the challenge, all of us. And I think that the analogy with climate change is, to some extent, applicable. If we look upon the global resource, clean air, and antibiotic effectiveness, we all need to take our part in this. All individuals need to know what it's about. Everyone needs to act what they can do, collaborate, and sooner or later, or hopefully sooner, create some momentum, a bottom-up momentum, instead of just a top-down. And this needs to happen. And it is coming. There are some groups around this that are voluntarily taking up this issue. Professional organizations, leaders, champions emerge. But if those groups, individuals could be, by the government, have some funding, some mandate, that will help a lot. Just one example from Zambia is that the professional organizations now, as forming a group, will take the leadership in cross-country stewardship programs, and that will be linked to the Ministry of Health and to the AMR focal point in the country. So I think that is something that should be supported, and I believe it's a real cost-effective initiative. It will, because in most countries it's a great knowledge. People know about this crisis. They want to act, but there need to be some mechanism for them to take place in the implementation. 1 minute, okay, sorry, time flies. So the ISCD has called for this, systematic support to civil society groups and organizations. But I think there is much more to do in that. So lastly, on the 1 minute, or maybe 1.5, in Latin America, we have a great group working with communities. Just now, a conference is ongoing on empowering communities with PAHO and other actors. The right on the right here is a tool for education in schools, where 3,000 plus students had already been doing these courses. It's moving also to Kenya. In Asia Pacific, working with a very bottom-up approach, starting with simplifying narrative, talking to people in the communities, what do they understand? What do we mean? What do we need them to understand? And then taking steps to measure the knowledge. Will emerge soon into a handbook for smart communities, which will include 15 indicators in all the 3 hex sectors, health, environment, and health, which I think could be a tool for benchmarking and to really getting the bottom-up approach moving and the context. This is a small village in India. It could be scaled up. And lastly, REACT Africa is very active in supporting many countries with development and implementation of the national action plans, as you can see in this colorful slide, and also hosting conferences every year with numerous actors from policy level, scientific level, and community level. And you can see there are many countries to the left. You see most of Africa, or at least very many countries, are coming to these meetings place every year to discuss. Last slide is that it isn't possible to put all this burden on a government in the low and middle income countries. There need to be global functions. One is a capacity building fund. The MultiPartner trust fund that you mentioned, Hanan, is too small. Absolutely, it's not in par with the crisis. Also R&D, not only for antibiotics, but for medicines, for diagnostics and bacterial vaccines as such need to be a global function. And at the very end, I think that we need to have a global agreement. Targets is coming, but they need to be agreed upon. And maybe at the very end, we need to have something like the Paris Agreement, also for antibiotic resistance. Thank you.
Otto, thank you very much. Sorry for being rude and rushing you. Is there one really quick question? No? Can I ask, I mean, Hanan talked about the face of AMR. And, you know, I'm conscious in this country, for example, 5 years ago, people didn't really talk about mental health. And then the two princes in this country, William and Edward, talked about their own experiences. And now I think a lot more people are talking about it. Likewise, Stephen Fry, the comedian, he did the same, etc. And it's completely changed it. You know, if I think of plastic pollution, 5 years ago, nobody understood plastic pollution. David Attenborough does one program. Now we've got kids cleaning up beaches in the summer holidays, etc. I think we do need somebody like that. I mean, in the US, they've got Michael J. Fox for Parkinson's, etc. I mean, if we had somebody like that, I think it would be quite attractive.
I think you're absolutely right, and I think we have been looking for those people all along. We had the honor to have the Crown Princess of Sweden at a very major meeting in 2010. But I agree, there some person that is well-known, respected, and visible should take on this. That would help a lot, I'm sure.
Jim Ratcliffe, David Sweetenham, that's a job for you boys. Okay, Otto, thank you very much. Thank you. Janet.
Thank you. So I'm Janet Midega, and I'm coming from Wellcome Trust, specifically the Drug Resistant Infections Program at Wellcome. And the work that I'm going to present today is not work that we as Wellcome staff have done, but credit goes to the institutions that have done the work. And mainly that will be the IHME, Institute for Health Metrics and Evaluation, as well as the University of Oxford's Big Data Institute. And we were part of the team that funded the work. And I worked very closely with the teams to help them deliver the research. So I'm going to talk about the global burden of antimicrobial resistance, the lessons that we learned from doing the work on the global burden of AMR, as well as the opportunities that work has opened up to us to work towards mitigation of AMR. So Wellcome has recently had a reorg, and so now we sit under the infectious diseases pillar in the interventions team, and we still are called the drug resistant infections team. So we've had a lot of these words this morning about the threat of AMR, how it could reverse gains that have been made by modern medicine, how it threatens already weak health systems that are unable to respond to pandemics and emerging and re-emerging infectious diseases at the same time as providing routine care. At the same time, we know that AMR is leading to higher costs of healthcare, longer hospitalizations, missed days of work, missed school. It's also threatening the SDGs that are directly or indirectly impacted by AMR. However, despite all of that, there is still limited action. And this is especially due to the lack of data. We all know in the room that there is a paucity of data on AMR or AMR burden, and even just data on the extent of AMR in different countries, as Dr. Hanan has highlighted this morning. So again, this has been said this morning. In May 2015, the World Health Assembly endorsed the Global Action Plan on AMR, calling on member states to develop national action plans. But before that, The then UK Prime Minister commissioned the O'Neill Commission, and they did a review on the burden of AMR. And the key goal of the review, of the Jim O'Neill review, was to frame AMR as an economic issue and to build a case for action for policymakers. And some of the outputs of the O'Neill review revealed some key statistics, which were excellent estimates at the time, which showed that there were 700,000 deaths due to AMR, and by 2050, there would be 10 million deaths due to AMR and a reduction in GDP. However, the other thing that the O'Neill review identified was the lack of a single estimate of the burden of AMR. So, how many people at any one time, in a year, for example, lose their lives due to antimicrobial resistance associated infections or attributable infections? So that led us to recognize the importance of burden data. What does burden data provide us with? It helps us to understand an issue, and so helps to create change and develop policy around the issue. It's also a key tool for advocacy and for making a case why AMR is an issue. And as has been mentioned this morning, AMR lacks a face. And so the data was needed in order to convince policymakers that indeed we have a problem. So what this has led to is the GRAM study. And the GRAM study is the Global Research in Antimicrobial Resistance, which was a 4.5-year project led by IHME, as I mentioned earlier, working together with the Big Data Institute here at the University of Oxford. It was funded by Wellcome, the Gates Foundation, and the UK Department of Health's Fleming Fund. And of course, Professor Sharon Peacock worked very, very closely with us on this project, advising us on how best to conduct this work. And the key goal of the GRAM project was to estimate the global burden of antimicrobial resistance by drug-bug combinations for the WHO priority pathogens, which had been established by the World Health Organization. So, what was GRAM? So, GRAM was a comprehensive examination of AMR in 23 bacterial pathogens and 88 pathogen drug combinations. So the pathogen and the drug that is used to treat it. So analyzing the extent of AMR based on 88 pathogen drug combination. The project looked at data from a total of 204 countries and territories. This project was very, very data dependent. It needed data from each and every country who could give data to the project. It also needed data from systematic reviews, research organizations, consortia. Pharmaceutical companies have data on post-marketing surveillance for the antibiotics that they have in the market. So we, as funders, Wellcome, Department of Health, and Bill and Melinda Gates Foundation, worked very closely also with pharmaceutical companies who have data, to speak to them, to provide data to the project team to include in the analysis for the burden of AMR. So this resulted in more than 471 million isolates analyzed to provide burden estimates, as well as 7,585 study location years that were included in the work. So this work is published. It was published in February this year in The Lancet. And so if people want to read more about it, you can find it online. I'll now go into the results. So I'll go into some of the key findings. The paper is wide. If I go into everything, it will take us more than an hour. So one of the key findings was an estimate of burden. So the GRAM study shows that there were 1.27 million deaths that are directly attributable to AMR in 2019. There were 495 million deaths that are associated with drug-resistant infections compared to no infection. And as you can see from the figure, to your left, the first 4 bars are estimates of burden in sub-Saharan African countries. You can see Western Sub-Saharan Africa is the first one, Eastern Sub-Saharan Africa, Central and Southern Sub-Saharan Africa. So you can clearly see that burden is highest in Sub-Saharan Africa, and of course in other low and middle income countries as well. So deaths associated with drug resistance from this work was greater than 250,000 each for 6 pathogens. So these are the leading pathogens: E. coli, Staph aureus, Klebsiella pneumonia, Strep pneumo, Acinetobacter, and Pseudomonas aeruginosa. And of course, all age death rates were highest in sub-Saharan Africa. So this is a graph, a pictorial representation of the distribution of the prevalence of AMR in different countries, but this is just for Klebsiella pneumonia. In the paper, there are several pictures like this for E. coli, Strep pneumo, and other pathogens, but I'll just take this as a snapshot to show you that the more red it is, the higher the prevalence. And you can see prevalence of AMR is quite high in African countries. And also, the data shows that AMR disproportionately affects children who are between 0 and 5 years. So like all other diseases, malaria, it highly affects children under 5. And that is particularly, if you look at this diagram, you will see that lower respiratory tract infections are also the leading infectious syndrome. Leading burden is higher in the lower respiratory tract syndromes. And when we look at all age rates of death, we also see that it is much higher in sub-Saharan Africa, as shown by the first 4 green bars. However, having shown that the all age death rates are higher in sub-Saharan Africa, the next figure, this figure shows data on antibiotic consumption, which is another piece of work that Wellcome funded at the same time within the Oxford group of the GRAM project to look at the volumes of antibiotic consumption. And if you look at this figure, you will see that this line here shows you antibiotic consumption in sub-Saharan Africa. So when we have higher death rates in sub-Saharan Africa, antibiotic consumption is actually much lower compared to other countries, compared to high-income countries, for which the graph is here, for example. So what does this mean? This means that there is an issue here with access to antibiotics in sub-Saharan Africa. So this data clearly shows us that AMR is now threatening healthcare systems worldwide. And this figure here shows the deaths per 100,000 that are attributable to AMR from the GRAM results. So, what are the key takeaways from the GRAM work? It shows us that AMR is real, it's a real problem, it's a real threat, it's urgent, it's relevant because it doesn't affect just one disease, it cuts across different diseases. It's relevant and it's preventable. And there are numerous things that can be done to prevent AMR. So, we also have evidence globally. We have evidence from Sub-Saharan Africa, Southeast Asia, Western Europe, South Asia, and Latin America, and the Caribbean. So this is not centralized in one place. It affects every part of the world. So what have we learned? When we were doing the data, supporting data gathering for the GRAM work, we found out that countries have data, facilities have data, consortia have data, but a lot of that data was not fit for purpose. Why? Because most of the data is centered on the isolate only. There is no corresponding metadata to complete the data set. Most importantly, a lot of data did not include patient outcome. So the data was just, this is the isolate, it was isolated on this day, what this drug was prescribed, what happened to the patient, nobody knows. Did they die? Did they recover? Did they come back after a few days for treatment? There's no information on patient outcome. So more data is needed. A lot of the data that we found was also not standardized. There's data in different forms, different shapes and sizes. That made it very difficult for the team to collate the data for analysis. So that led to a lot of modeling estimates for low and middle income countries. But we need better data to guide policy and to provide numbers to promote action. We are also now aware that there are pathogen drug combinations that are at greatest risk. However, the whole list of priority pathogens are at risk. The drug-bug combinations that were analyzed are all at risk. So it's going to be very important to preserve the antibiotics that we have. But how will that happen? Only if we develop diagnostic and antibiotic stewardship measures. Microbiology laboratory capacity is also still lacking, especially in low and middle income countries. A lot of prescription is empirical. There is no diagnostic processing that accompanies the prescription of antibiotics. So we also learned that research in each of the leading pathogens warrants more attention. There is need for funding, capacity building, research and development, and in fact, pathogen-specific priority setting, especially because the prevalence of resistance for the different pathogens on the priority list is very variable across different countries. The picture is not the same in Asia if you compare to Africa. So, for us at Wellcome, the Graham study, which estimated the burden of AMR, has opened some opportunities of work for us that we can then fund in the process of working with partners like the ICG that has been mentioned, React Africa, and ministries of health at the country level in order to help mitigate AMR. So, what are some of the opportunities that we're taking advantage of? So we have work that Wellcome is funding to improve AMR surveillance at national and regional levels. We need to develop tools for AMR surveillance. We also need to work very, very closely at the country level. It has been mentioned this morning that a lot of countries have national action plans, but these national action plans are not implemented. Why? Lack of funding. So we are also developing work to work very closely with ministries of health so that we can strengthen capacity for AMR data analysis. But not only for the countries to analyze the data, but to actually use the data for action at the hospital facility level to improve patient care, nationally to help improve treatment guidelines, but also share the data regionally and globally with GLAS and WHO. We are also working towards projects on infection prevention control and also antibiotic stewardship and maintaining investment in the development of a pipeline for new antibiotics. And most of you in the room will have heard about CABEX, which is funded by Wellcome as well. So I will now go on to mention some of the work that Wellcome is actively funding in line with lessons that we have learned out of the global burden of AMR work. So we have recently approved funding for the second phase of GRAM. So you will realize from the GRAM paper that the burden analysis that was done was at a regional level. So GRAM 2 will now provide more robust estimates at the country level. Apart from that, for the GRAM 1, countries mostly gave data. In GRAM 2, what we are doing is working together with countries to generate their data in a longitudinal study, but also helping countries to analyze their data and to develop expertise for data analysis. So I'll just look at the top here at the 4 work packages that are covered in the second phase of the GRAM work. But I'd also like to mention other work that we are funding, which is work on a clinically oriented antimicrobial resistance network led by Paul Turner. And the aim of this is to work towards solving the problem of patients not being the center of AMR work. So the ACON protocol works at developing, implementing, and assessing an enhanced AMR surveillance protocol that puts the patient at the center of AMR surveillance so that the data out of any AMR surveillance activity comes back to be used to improve patient care, develop antibiotic prescription guidelines, as well as improve overall patient in the hospital. And also important to mention that the ACON protocol is fully compatible with the WHO GLAS requirements and also the WHO attributable mortality protocol. The other piece of work that has developed out of our GRAM funding is a sustainable partnership to improve data for action against AMR in partnership with Pfizer. Pfizer were actually the pharmaceutical company that provided a very high volume of AMR data that went into the burden of AMR data analysis. And for this work, we're piloting in 4 countries, mainly Uganda, Malawi, Ghana, and Kenya. And for this, we are working very, very closely with the ministries of health. We met with them, asked them what were your priorities. Based on the National Action Plan, where surveillance was a priority, we are then working with them on a protocol, which we have co-created together to answer the questions on AMR surveillance that they have at the country level. And including in this, we're working at specific hospital sites, so we can bring the solution to where the problem is, which is in the hospital, where improvement of care needs to be supported by data. And in the process, also promoting data analysis and data use at the hospital level. Thirdly, I must mention that we have CEDRIC. CEDRIC is Surveillance and Epidemiology of Drug-Resistant Infections Consortium. It's a think tank that we work closely, very, very closely with at Wellcome to help us to identify priority areas of work that needs funding. Next is CEDRILIMS. In the process of doing the burden of AMR work, we've noticed there's very, very poor mechanisms for data capture. There is not a microbiology-specific laboratory information management system. So with advice from Cedric and the team that at the time was led by Sharon, we identified surveillance through discussions with Cedric as a cornerstone for AMR global containment. And it was also clear that it's very challenging for low and middle income countries to generate data because data is in different shapes and forms. Some data is on paper. There was need for a unified data capture system. So Cedric concluded in 2019 that we need a freely available microbiology laboratory information management system. So we went on to develop that. We call it CEDRILIMS, CEDRI from Cedric and LIMS Laboratory Information Management System. We have now completed the first phase of development. We have the LIMS, it's up and operational. We have completed piloting in 5 countries. We are now going straight into the next phase of real world testing for the LIMS so that it can be operational. And in 3 years, we hope it can be made available freely to countries that need it. It will not be complete if I do not speak about work that we're doing with Professor Tim Walsh on understanding the impact of COVID-19 on bacterial sepsis, antibiotic consumption and stewardship, and antimicrobial resistance. And this is work that is ongoing in the countries that are listed to try and understand the extent to which antibiotic consumption has increased during the COVID pandemic in these countries. And these are the objectives of the study, and I will not go much in depth into this because some of you in the room might be very familiar with it. But I'd just like to mention that this is an example of how work on AMR can be embedded into existing public health programs, because working on AMR as a standalone activity is not effective in the long run, and especially because AMR is a problem across different disease systems. So we are trying to, with this project as an example, to embed AMR activities in other existing disease areas of work so that it can become part of the activities on a day-to-day basis rather than isolating work on AMR and ending up working in a silo. So I will stop there and just say that AMR remains a problem. Urgent action is needed to prevent AMR from sinking the modern medicine ship. And this is a graphic that we did when we developed when we did our campaign following the drum study. And I'll just like to also thank all the different people, the GDB collaborators, some of whom are in the room, and the different funders as well as the Wellcome DRI team. And thank you for listening.
Janet, thank you very much. That was fantastic. I love that paper that came out in January. Superb. Is there one really very quick question?
Yes.
Please, Chris. Very quick.
So Janet, it seems to me you identified a very specific problem. You identified a very specific problem. That is under 5s and respiratory disease in sub-Saharan Africa. So. Why is that and how do we solve it?
So I think that is especially, first of all, that comes across because there are many different illnesses in sub-Saharan Africa that present with similar symptoms. And so the reason why sepsis ends up killing most under 5 children in Africa is because of late diagnosis, late identification of the problem. And the other problem also is, I think there is some controversy around the best antibiotic for use. So at Wellcome, we have not directly tackled this problem, but at the moment we are working very, very closely with the AMR team and the Bill and Melinda Gates Foundation to actually do further work on AMR and sepsis in units.
Janet, that was such a beautifully clear presentation. Thank you so much. Fantastic. Neil? I'm going to get such a spanking for this after this, for bad sharing. So Neil, help us.
I've been asked to gallop, so I'm galloping. I have a declaration. I'm not an expert on AMR, and you'll be relieved to hear I'm not going to show any ghastly pictures of infected wounds. I have worked here in Oxford for about 30 years. I'm the bowels rather than the bones. And in 2002, in a timely fashion, when COVID broke out, I became president of the Royal College of Surgeons, which has a leadership role in surgery in the country globally. In surgery, we talk about surgical site infection. You all know what that is, a red hot wound, patient has a temperature. It's responsible for 20% of all healthcare infections, and around 5% in Western societies, if I can use that term, of surgeries are complicated by a wound infection. Interestingly, most are caused by contamination from the patient's own body. And this NICE guideline, updated in 2020, goes through all the sorts of things we try and do. I'm not going to read them all out. Many of you who've been to surgery will have been through this. These are the things we routinely do to make sure the patient doesn't get an infection, and particularly antibiotic prophylaxis. If there's a clean wound where we put in an implant, for example, a joint replacement, if the clean wound becomes contaminated because we've burst the gut in some way, or the patient presented with peritonitis or the road traffic accident and they've got bugs in the wound straight away. You'll all know from many, many television programs, these are the things we do intraoperatively to stop you getting an infection. And interestingly, this document suggested there was lots of room for research and further work in these areas, the whole area of nasal decolonization, antiseptic skin preparation. Surprisingly, should it be alcohol-based or should it be water-based? Should we bung antiseptics and antibiotics in the wound? We still don't really know. And what are the best closure methods to stop an infection happening? Now, I'm going to take you to the beautiful city of Gorky, just for 2 minutes. This is the Volga, and the city is sometimes called Nizhny Novgorod. And in 1989, as a very young surgeon, I was asked to give a talk at the All-Russian Soviet National Surgical Meeting. And I visited this hospital, and I have to tell you, it was shocking. In the 1980s, Russia didn't have widely available antibiotics, and the surgical ward was divided in two. The first half was a massive dressing station, and the second half was actually beds with patients in them. Most of the ward activity related to taking patients who'd had surgery, bringing them to the dressing station, cleaning their wounds, and then taking them back to the wards. The infection rate was horrific, the mortality rate was horrific, and it gave me a sense of just how far we'd come with prophylactic antibiotics. And in fact, I can tell you very briefly, in 1991, a senior Soviet official came to Oxford for me to operate on them because in Moscow, there weren't the available antibiotics. Around 50% of patients had an SSI before antibiotic prophylaxis, with the obvious increased mortality, length of stay, the wound management we talked about. David and I will remember the days when students at a certain stage during their medical training were called surgical dressers. Part of their job was to do the wound dressing. We just don't see that now. Obviously, chronic infection and the cost involved. In 2016, when I was editor of our in-house journal, the Bulletin, we had a series of what-if scenarios, and this was one of them. What if a superbug stopped all open surgery indefinitely? What we didn't realize was that shortly later, this was about to happen. This is 2020, April, and surgery virtually stopped. Stopped for two reasons. One, we didn't know what would happen to people who got COVID around the time of surgery. And number two, the government stopped all planned surgery. So it's not all related to a virus, but it is all related to a general pandemic. And the orange bars are the cumulative losses of operative capacity over that time. So a massive effect. If there suddenly arrived a bug to which we could not provide the appropriate prophylaxis in surgery, surgery would stop dead. So the prophylactic antibiotic era started in the 1960s, and it has had a dramatic effect on infection rates, down from 50% to 10%. Just two or three areas to remark upon. Here are the bones. The source of infection in orthopedic surgery is usually airborne and skin, and those are the bugs. You'll know about laminar flow in operating theatres, pushing the air down away so that the bugs don't go in the wound. And of course, the major problem for orthopedic surgery is the putting in of an implant. And if we use antibiotics and the implant, we can reduce surgical site infection. If you imagine 100,000 hips and 100,000 knees being done in NHS England per year, if you just increased the surgical site infection by 5%, that's thousands of patients. And that will account for lots of revisions and lots of time spent recovering, lots of cost, and an increased mortality. And I could go on and say more about that, but I'm galloping. Clearly, in the trauma zone, if you have bugs pushed into the wound when you have a road traffic accident, that's the bone and the skin and the muscle. Really, really difficult problems, huge cost, and huge extra morbidity. So here are the bowels, and that's my area. We have huge problems if we get infected wounds in gut surgery. And when I was in Nizhny Novgorod, around 50 to 70% of the patients, as I was saying, got a wound infection without prophylactic antibiotics. Slow wound healing, incisional hernias, high risk in immunocompromised patients, liver transplants we've heard about, poor nutrition, IBD, cancer, massive increased mortality. All these things we take for granted and assume are part of routine surgery would completely disappear. There has been some harm from the use of prophylactic antibiotics, and for a while we had big problems with C. diff. There was an epidemic in the 70s due to the use of an oral bowel prep called clindamycin. It's still there in the background. We still have to be careful of it, largely as a result of antibiotic use. And of course, we know about MRSA and the way in which, if that gets particularly into orthopedic wounds and into bones, it's an absolute nightmare with a raised mortality. Just briefly then, what are the opportunities in surgery for antibiotics, for alternatives to antibiotics? There's quite a lot of evidence that if you halfway through the operation, just before you're going to close, if you take all the drapes away, get clean again, start again, although that sounds expensive, you can reduce surgical site infection. You're all now used to hearing about minimally invasive surgery, keyhole surgery, for example, for gallbladders. Even though minimally invasive surgery and robotics does reduce surgical site infection because the wounds are much smaller, prophylactic antibiotics will reduce surgical site infection. And just looking into the future a bit, this is something of interest, vacuum-assisted wound closure, where we actually put suction pressure on the wound. That seems to improve surgical site infection. And there has been a return recently in this paper in the BMJ, just published in bowel surgery, again, using oral antibiotics to try and reduce surgical site infection. Again, this is a very, very controversial area, and we're scared to go back to the C. diff issue, but very interesting. So I've galloped, and the balance is we need prophylactic antibiotics to reduce surgical site infection, but clearly the injudicious use of those antibiotics, particularly in surgery where they're used a lot, will risk the emergence of AMR, and quite probably in many, many surgical procedures, around 30% of cases, the wrong antibiotic, and the wrong dose and the wrong duration of dose. All these things are really important. The timing, the type, the duration, the patient's weight, how soon you give the antibiotics during the start of the procedure, how long the operation lasts, and so on. All these things are there, but it doesn't always happen. There needs to be a culture change, and it's already been alluded to. There is a sense in which we use antibiotics as a comfort, as a way of helping us allay our fears around what might go wrong, and that leads us to using antibiotics inappropriately. There's a lot to be done to look at surgical prescribing habits, particularly for antibiotics in this arena, and to improve antibiotic stewardship. So what can we do? We can change behavior, but in the surgical world where we're terrified of things going badly wrong, and we've come to assume that no infection is routine, is difficult. We can further investigate and promote non-antibiotic measures, so we don't need to use antibiotics for so long. We can innovate around delivery and dosing, and clearly the suggestions from NICE around research, and particularly in the surgical community, would be very, very helpful. As you've seen, alongside the vulgar, back in 1985, there was a major problem with infection on the wards, and the wards weren't like the wards you see them now in the John Ratcliffe or the Churchill Hospital. Half the ward devoted to cleaning and managing wounds. We don't want to return to that catastrophe. I hope that was a gallop quick enough. Thank you.
That was a beautiful gallop. Thank you so much. David was taking loads of notes. I don't know why. So any quick question for, please, Otto.
Thank you so much.
Microphone.
I just want to congratulate you for the talk, and also the narrative you're now telling us is exactly what people need to know. So this is exactly how we can convince everyone about this crisis. A specific question, in the very early talk you mentioned that bacteria came from our own body and our microflora. I think that is another issue that we might bring up in the discussion. How many of the infections that we are really talking about are coming from the microbiome? I don't have a figure. I tried to find a figure, but I think it's many, maybe a majority even. And that could also help to drive understanding on the individual level, not that this is a crisis for the world and for coming years and whatever. It's for me to save my own flora. So thank you again.
Thank you.
Thanks a lot. Let's move straight on to the panel discussion, because Sharon's going to beat me up after this, I tell you. Where is Sharon?
She's not in here.
Oh, she's not. Well, maybe I won't get beaten up. Arlene, please, come on. And I think we want all the speakers up here as well. Is that the plan, Clara? Please. Yes. Just sit somewhere. Okay. Arlene, tell us about your experiences.
Thank you. Well, thank you very much for the invitation to be here. I lead the patient support programme in a charity called Antibiotic Research UK. I've done that over the last few years because the charity identified very quickly that there are patients out there struggling with these resistant infections who have nobody to talk to, no sources of information except Dr. Google, and they needed that help, support, signposting, etc. So it's been my joy and privilege to set this up and to hear from those patients. We don't give medical advice, of course, but we do listen. We're able to signpost, support, bring them together. And so I thought, we've heard today that AMR that really lacks a face, Janet said. I would like to try in the few minutes as we start this to put a human face around that from the experience I've had. So if I can give you one or two examples of patient stories with their permission, but maybe before that I could summarise what I've learned about the patient experience on this kind of a journey. And the first thing that you hear is nobody in that public arena understands this until it happens to them or someone in their family. So in other words, they don't get it until they get it. Language is a real problem. We've talked this morning about antimicrobial resistance, stewardship, AMR. We've lost them by then. So the patients need a very different language and approach to all of this. So if we're going to work together, that's a challenge, isn't it? There's a lack of patient information generally and time to counsel patients properly. So, they'll leave hospital and they'll say, I'm told I've got an ESBL. What does that mean? Can I cuddle my family? Can I live in the same room? We need to do a better job, I think, of getting that patient information on those kinds of problems. I think the thing that struck me most is patients talk about living with fear and dread. The dread of that next flare-up, because often these infections are not one-offs, they come back again and again. And the fear is about that time when they're maybe told there are no more antibiotics going to work for this, or you're on the last antibiotic we can use. And I hear that frequently. They don't talk about it a lot, but it's in their head. And so I think what we begin to see is this is like a chronic condition, but it's invisible because they look very well. And that means it's very difficult for friends and family to understand as well. They talk about compassion fatigue setting in. They're not well, they're usually, they're not reliable, they don't bother, it won't be able to happen. And so it's a very difficult world that they inhabit because of this. So people don't understand, and they talk about not being believed because they look very well. And sadly, they talk about that within the healthcare community too, that doctors and healthcare professionals will sometimes not believe them either. Some of them talk about being referred down the psychiatric route because the tests have said there's nothing wrong. That's a very difficult place to be. And so as a result, it's a very isolated place that they find themselves. They think they're the only one this is happening to, which is why I think the programme that we run gives them that. It's a relief, I think, that they're not the only one and they can meet with others who understand that journey that they're on. So that's some of the kind of context within which, no matter what kind of infection it is, that's the kind of experience that they're having. So if I were just to give you one or two examples, Rhonda, who lives down in this part of the world, went into hospital for surgery for endometriosis about 3 years ago. She then had a catheter-acquired UTI. It wasn't, unfortunately, diagnosed correctly at the time. It was a multi-drug resistant one. It wasn't treated properly. She was discharged, and then within days, she was taken back in with sepsis. So for her, she's now in a position where she still has this bug, she still has these flare-ups, and they have completely derailed her life. She talks about how it's not just her physical health it affects, it's affected her mental health hugely. She's had periods of depression and anxiety because she's lost her job. She's relying on her partner to support her now financially. She's become unreliable. It's affected her social life. So the impact is huge. It goes way beyond physical health. She would say to me now, it's far worse than the problem I went into hospital with. And something she said to me has always stuck and resonated, because she said, I live in fear of sepsis again, having been through that. And she said, I realised that I'm 1 step away from sepsis, 2 steps away from death. And that has stuck with me because that's the reality of her experience. I struggled to think, who else would I tell you about? Because I have so many different stories that I'd love to share with you. I could tell you about Nicola, whose husband had 2 stem cell transplants because of a lymphoma condition. She told me that for her and her 2 teenage daughters, actually the resistant infection that he picked up was a bigger trauma to them as a family than anything else he went through with the stem cell treatment. It was that constant going into rigors and going into the serious stages of infection, the blue light into hospital, 12 hours in an A&E department, trying to explain to staff that actually he was immunocompromised. He needed to have a separate room and a separate toilet. But of course, we know the struggles in the NHS at the moment. And she said for her and her daughters, it was far more traumatic to deal with that and these infections that just kept occurring. She talked about how she had a heart sink moment when they gave him the same IV antibiotic, because really they were at a stage where there weren't many options left. but she wanted to be able to talk about, is there anything else? Because they knew he would have that treatment, he'd be released in a few days, and then within a matter of days or weeks, it would all happen all over again. And so they lived in this state of fear, watching him all the time. And so actually the infection was worse than the lymphoma or the stem cell transplants for that family. He sadly died of a different reason, actually. But today, the family are still living through the impact of that. His wife has become really unable to make decisions. She says she had to make so many quick decisions at the time. She now is a bit paralysed by it all. Their daughters have become quite withdrawn. They've thrown themselves into work or had to take time out of university. It's had these tangible impacts. And she's very clear that it was the infection and what they went through in that caused that. So I think we begin to see it's not just the individual, it ripples out to the whole of the family, and it has impact on so many people.
Arlene, that was fantastic. Thank you very much. Can I kick the question off by asking, how many of the people you talk to understand antimicrobial resistance?
So I think one of our first sentences is really to say, so antimicrobial resistance is where, and we start to talk about bugs, not bacteria, then we move to bacteria. We have to change the language totally. I use a very different language with patients than I would use as a pharmacist background with my healthcare professionals. I have two different sets of language.
Is it too late to change this terminology? I mean, I'm just conscious people like quick messages, you know, get Brexit done, you know, sort
Yes.
of AMR. I mean, I'm just worried. I mean, and Colin has said this to me many times in the past. You know, some people don't understand resistance, and then you're talking about antimicrobial. And Janet, on the manuscript you had, it was bacterial antimicrobial resistance, etc. And sort of.
Yes. Yes.
Otto, you're about to say something. Please use the microphone.
Thank you very much for sharing your views and elaborating on this. Fantastic, really. I cannot agree more. Well, if you come, it's not only patients and people, it's also politicians, really, and policymakers. So if you come to a minister and have 1 minute wherever, and you say, oh, dear Mrs. or Mr. Minister, you have 35.6 ESBL XYZ in your country and you have to do something about it. Nothing will probably happen. So even policymakers doesn't really know. And I think that the AMR community should be a little bit ashamed of not having agreed on a common terminology, because I think even in the so-called AMR community, we are not defining AMR and antibiotic resistance the same. Because some say that AMR is the broader concept with malaria resistance to HIV, parasites and whatever. And then we have the bacterial antimicrobial resistance from Gram, which is really odd. So I think we need to do better. I agree completely. But if we can change, I'm not sure. I think the sort of policy circles might cope with this somehow. But I think for the people, we need something else.
Can I, Jim, you're looking very thoughtful. I mean, I was intrigued by that story you were telling about, you spoke to some head teacher and you've got kids running, you know, before the age of 11, a mile every day, and you've got so many kids now across so many countries. Is there something like that we could do, which is more bottom up? Because my worry is if we expect loads of governments to come together to come up with a solution, it's not going to happen. You know, big changes happen because of industry or because of certain individuals.
It clearly would do no harm if there was something catchy that sort of got the attention of the younger generation, that, you know, they sort of got into their heads and then they start to talk about it. You know, they go to the bar and chat about it, but they're not going to chat about AMR because nobody would understand that. Superbugs maybe, but, you know, I mean, you are correct. I'm not sure quite what the answer is. I mean, we did talk about it at one of the board meetings recently, David, didn't we? That, you know, you need to sort of generate that sort of topic of conversation with the younger generation where they get passionate or fervent about it, like, you know, anti-shale or whatever. You know. Yeah.
Thanks. Janet.
Yes, I'd just like to comment on that line along the young generation. So in 2021...
You notice she looked at me when she said young generation.
In 2021, Wellcome actually funded an activity that was trying to educate teenagers from about the age of, I think, 10 to 17 on AMR, and it was a schools engagement program. And so this was to find out how much did they know about AMR, how much of a lived experience do they have with AMR. So they then had to speak to their families and come and feedback, and I think we actually have a video about it. The Ministry of Health, it was done in Kenya. The Ministry of Health in Kenya were involved, and I think there are plans to actually include it in the school's curriculum. So there is some activity around that. I think what we probably might need for this is some scaling and maybe just widening it beyond the pilot. So
You're doing
Wellcome
so many
has
great
tried
things, Janet.
something.
Fantastic. Thank you. Colin had a question. Colin, please wait for the microphone.
Thank you, Chaz, and thank you, panel. Can I throw another dimension in? And first of all, I want to address Arlene and Neil, and thank you for grounding some of that conversation. I was very moved, Arlene, when I first met you, and when you spoke on those things. These sort of days remind me to a degree of like being in a room like this in an aircraft. I sit down, I listen to the screen, watching all the warnings and things we should do in case of an emergency. The staff are busy preparing, seat belts, sitting upright. And then it's a real experience I had. I sat on the tarmac for half an hour, then realized there was no pilot in the cockpit. And to a degree, the story of AMR, I think, I'm not speaking about governance, which we have plenty. I'm not speaking about the officials and the policymakers and that kind of tier. I'm speaking about people who've got executive capacity and capability. And this is at an international level and at a national level and often at an institutional level. People who are able, I think several of the panel speakers spoke here about driving things through. And I think with Ineos, you wouldn't have got the growth you had without people who were prepared and willing and able to drive these things through at an executive level. Thank you.
Thank you, Colin. Any comments? We've got no pilot. We're flying blind.
Again, I'd just like to mention, this came up actually when the Graham report was published, and a question came up about for diseases like malaria, we have PEPFAR, we have the National Malaria Control Programs, and for HIV we have PEP. We have also Global Fund for malaria. We have various international organizations that focus on malaria, that focus on HIV, that focus on TB. Why don't we have something similar for AMR? I do not have the answer. Maybe.
Hanan, are you our pilot?
I'm a co-pilot because I think this is really, we go back to, I want to maybe just talk about, for a second, about the face of AMR. The thing is, I don't think we should blame ourselves too heavily as communities because AMR, it doesn't have a face for a reason, because it's difficult to have a face. So we can't keep accusing ourselves of failure. I mean, when you look at why does HIV have a face? I took care of HIV patients. They're cachectic. They were wasted when they're not on anti. Why does polio have a face? Because the limping and the paralysis and the iron lungs. Why does TB have a face? Because coughing blood. Just one little thing. AMR is difficult. We actually, I'm challenging people even in my meetings. Give me an idea and WHO will fly with it. But I have not heard as of today a brilliant idea on a face. Celebrities, yes, we can go with that. Now what we're trying to do, there's a platform specifically for the patient voice that are, so in the Quadripartite, we went from an antibiotic awareness day to an antimicrobial awareness week with a focus on, because we get our TB, our malaria and everything, but there's focus on bacteriology as well. So that's one thing that we've changed collectively to bring in the voices. And we're launched, I don't know if it was launched this week or a few weeks before, a platform for the Quadripartites, but it's for the community. And we had a call for people to apply for the patient voice. So we're hoping that when we end up having more information and more data, I can give you tons of stories from my 20 years of being on the ward that are, very dramatic of antimicrobial resistance. The other thing that we did on our strategic advisory group, one last thing, on our strategic advisory group for AMR, we actually have a lady who's with us who's a patient voice. She had major trauma to her face with dramatic bacterial infections, and she keeps an eye on the strategic group so that we have the patient voice with us. So these are just some examples.
Thank you very much, Hanan. Look, I've been told we've got to close, but I want to hear the questions. So could you just share your 1, 2, 3 very quickly, 20 seconds each, please.
Heard a lot about the impact.
Can you say your name and where you're from?
Sorry, Dr. Adam Carey, working alongside Ineos.
Yeah.
We've heard a lot about the humanistic impact of antimicrobial resistance and a lot of focus on collecting data around what's happening in the human population. We know there is a problem, yet the elephant in the room seems to be that 70% of our antibiotics are used in the animal world, and we haven't had a single message about what we're doing about that, how we're going to manage that, because that's where the resistance is coming from.
It's a great point. Tim's worrying about it day and night. Please just rattle off your questions.
Hi, I'm Jake McKnight. I look at antimicrobial resistance in Kenya and antibiotic stewardship in Kenya. My question is about the use of behavior change as a phrase, and the idea that the people who are consuming antibiotics or prescribing antibiotics have much choice in that in some occasions, because I know most people here, if their son or daughter had some kind of terrible bout of diarrhea and they were 10 kilometers walk from a health facility where they had to queue outside and then got partial disinterested treatment from a clinician, that they too might go to the local pharmacy in the local market and buy some antibiotics straight that way. Behavioral change as a message is probably not going to shift them in that regard, but similarly to the doctor that needs to make it around and see 40 patients and needs to make sure they are treated in some way is not going to shift because he got a pamphlet that had really nice diagrams on it.
Thank you.
So yeah, just
thank you very much. One behind you and one in front, I think, and then we're going to wrap it up.
Thank you. So,
20 seconds, question.
Yeah, all the speakers have been shouted at, so I'm going to be shouted at next. Okay. But I will keep it very brief. Pete Borriello, I led the UK strategy on reducing antibiotic use in livestock and in companion animals, and I've worked extensively on the human health side in the past. Yeah. So this is truly One Health and is meant to be, but you're quite correct, we haven't heard anything on the animal side. Yeah. My point's related to the panel discussion primarily, which is it's not about a face for AMR, it's accessible language. Then we have to stop the arrogance of believing accessible language is only for the layperson. It's for most of the professionals and paraprofessionals as well. And most people's interaction on this subject is with other professionals and paraprofessionals. And in many cases, not only are they ignorant of what AMR is, they actually give the wrong information about what AMR is and perpetuate the problem. So it's about that. My final point is, in science, it's the accuracy of language that's critical. So everyone's talking about resistance, when most people are talking about decreased susceptibility, because resistance is a clinical breakpoint, not an ECOF. Thank you.
Okay, thank you very much. I think we're going to have to stop it there. Ladies and gentlemen, thank you very much, and thank you to the panel. And I'm sorry for being such an awful chair. And thank you in particular to David and Tim and Chris. And where is Sharon? Because it was these four who organized this. So many, many thanks, and thank you all again. Thank you. Arlene, thank you very much.